Welcome. It is our March AZ Low Carb Forum. My name's Allison Ritterford. I'm a certified nutrition consultant, and I get to be your host this evening. Tonight's topic is one that I have been really looking forward to hearing about. Cory Jenkins is going to talk about de-prescribing. That's getting rid of medication as opposed to piling it on us. He'll address lifestyle changes, how to talk to your doctor, and I'm sure we will hear some probably funny and entertaining stories. This meeting to an hour. So let's get right to our speaker right after a couple of housekeeping items. This meeting is being recorded. I mentioned, I think you might have all been on the screen, but the meeting's being recorded. If you don't want to be on the video, just turn your video off. If you'd like to change to just your first name, please do that. You use the three dots up on the top right corner of your picture. I also would ask that you keep yourself on mute. I already said that. Everybody is complying. And keep track of any questions that you have during Cory's presentation, because after the presentation, we are going to have time for a Q&A session. So write those things down, and right after we should have plenty of time to ask him questions or ask questions of any of the practitioners that are here tonight, because we're all happy to answer. Our speaker tonight is Cory Jenkins. Cory earned his Doctor of Pharmacy degree from the University of South Carolina in 2011. Since then, he has practiced as a retail pharmacist, outpatient clinical pharmacist, and inpatient clinical pharmacist. He currently is a practicing clinical pharmacist and an improv comedian. Cory travels the country teaching healthcare professionals how to apply the valuable skills of improv comedy to create a more adaptable, empathetic, and humanizing healthcare experience for both patients and providers. Cory lives in Tucson with his wife, Cassie, their 2 children, and 10 chickens. With his presentation titled, Fire Your Pharmacist, please welcome Cory Jenkins. Take it, Cory.
Thank you, Allison, for that introduction. Let me go ahead and get this thing shared with everybody. A couple of updates from that intro. Unfortunately, I now have 8 chickens. The coyotes got to a couple of them. Not to start this topic off on a sad note, but nature happens and coyotes got to eat too. And we are going to be building a bigger chicken run. The coyotes took 2 chickens. I was in my yard. They were wily. I will say that. So so I'm a pharmacist, and today the title of my talk is Fire Your Pharmacist, a conversation on medication, de-prescribing, and chronic disease reversal. And so you got that introduction. I'm definitely not a normal pharmacist, but I'm not a typical pharmacist in that when you think of pharmacists, you probably think of going and getting a prescription filled at like a retail pharmacy. So we'll just say the big ones, Walgreens, CVS, and poor little Rite Aid that's hanging on still. And so, but what I do, I work for a healthcare facility that allows me to do what's called clinical pharmacy. So many people don't know that pharmacists can do residencies. I'm residency trained. You see these fancy letters after my name. The letters don't mean anything, but they mean I'm board certified in 2 different specialties. But what all this means is I actually kind of act as, if you think of like a physician's assistant. So my job, and the reason I'm a comedian, but I'm also talking about metabolic disease, is that I help manage chronic diseases like high blood pressure, diabetes. So the flow of my job, and I have to, if you're kind of like, I don't follow this, Cory, don't feel bad. My parents really don't understand what I do. In fact, my mom didn't know what I did until she read the book that Allison mentioned that I'm going to disclose here in a moment. So the money and time of writing a book, not about my normal job, helped my mom know what I do. But think of me as like a physician's assistant. So if you are diagnosed with diabetes or high blood pressure, or I do a number of other things like smoking cessation, you go to your doctor, they say, oh, they check your blood pressure, I'm starting you on a medicine, I want Cory to follow up. I can actually prescribe medicine. So we have an appointment just like a doctor. I take your vitals, or I do it over the phone, and you tell me your blood pressures or blood sugars. I have prescriptions go out that say Cory Jenkins on them. I'm not the pharmacist checking it. I'm a pharmacist that gets to order it. And so the whole crux of my job, the whole crux of ambulatory care clinical pharmacy is to help manage chronic disease. But we're not here to manage chronic disease, are we? Oh, we're here to reverse chronic disease. And that's what I want to talk about, because I'm kind of, the whole topic here is very clickbaity, fire your pharmacist. But I want to talk about medication de-prescribing and chronic disease reversal and not management. So a couple disclaimers, none of this is medical advice. This is entertainment and educational, it's edutainment. But always consult your individual healthcare practitioner or your pharmacist. You know, if it's a medication thing, we're pretty good at this stuff. And there's a lot of great resources for pharmacists actually that have been put in the literature to help with people just maybe just like you. I don't want to assume, maybe just like you who are on medicines for blood sugar or blood pressure or cholesterol. You're starting a new way of eating and you might not need as many of these medications. So we want to be safe when we do this. Now, my disclosure. So my wife is a nurse practitioner and she works for this company called Virta Health, and they do ketogenic diets for diabetes reversal and weight loss. So inherently, I am married to a biased way of approaching metabolic disease, low carb and keto. Again, we're called AZ low carb. So I hope you're not, I hope you were sitting down when I told you that. But I think it's only fair that I say that I'm married to someone that practices in this way. And I keep bugging her to tell that Virta needs pharmacists, but we'll table that for now. I personally follow a low carb lifestyle. Am I keto? Probably not. I haven't checked my ketones like ever. And I eat fruit and sweet potatoes sometimes. So maybe they'll kick me out of the low carb club, but I get away with it for now. So, but I don't eat a bunch of the junk stuff. And I will say, this says present tense, I do receive book royalties. I've not received any book royalties yet. This book here, Permission to Care, Building a Healthcare Culture That Thrives in Chaos, came out last month. It has nothing to do with low carb, but I actually think it has a lot to do with the approach that you as a patient can take with your provider, that providers can take with patients, and a holistic view of how we're approaching this disaster of metabolic disease. So while it's not a low carb book, I bet you that if more people read this book, we would have more progress in improving our overall metabolic health, because it's very easy to have the nuts and bolts of carbs and fats and proteins, but it's very difficult to convince people who think otherwise or to work with an individual patient on the barriers that they're facing. So, but it's only fair that I bring that up and then I guess shamelessly plug it. So I'm a pharmacist. So what I would love is to get some word association. When you think pharmacist, what do you think? If you want to unmute yourself and say it, you're welcome to. If you want to put a thing in the chat, you're welcome to. And I know people can be a little bit nervous with a group of strangers. So I'm going to start here. I'm going to make this really easy. So I'm going to look at this specific pharmacist. You can think of any pharmacist in your life. If you've seen them on TV, tell me about it. We're not really well represented in media. We're not a popular medical drama genre. I'm looking at this pharmacist here, and I do not trust this guy. Look at him. He's on his individual personal cell phone. That is not HIPAA compliant. There is patient information going on. So either he is talking, unless he's using doximity, he is disclosing patient information, assuming he's talking about patients. He could be talking to someone not even to do with his job. He could be looking at a medicine and talking about, betting is legal now. He could be placing bets. I don't know, ordering food for lunch. Good luck. He's a pharmacist. He's not going to get a lunch break. Joke's on him, right? He doesn't seem sure of himself. So I don't trust this pharmacist, but what do other people think of pharmacists? So Susanna says medicine. Oh, that's right. That's what I do. I do medications. I verify and I'm told I need to prescribe medication. Allison says medication. Dr. Pete says white coat, pills in hand. Yes, this guy has a white coat on, except he looks like some sort of eye drops, which eye drops can be used in the ear, but you should not use eardrops in the eyes. That's, if I remember anything from pharmacy school, that's what I remember. So, but yes, we think of pills, the white coat. I haven't worn a white coat in literally 10 years. I worked at CVS Targets when they were just Targets. And that was probably the last time I wore a white coat. We're pretty laid back where I worked. So yeah, white coat, pills in hand, pills and medicine. That's what we think of with pharmacists. So, and you're generally probably right. That's what we're known for. That's why I went to school, because I thought I'm going to help people with medicines. Now, do we trust pharmacists? I know I was making a probably terrible joke with this guy, but do we trust pharmacists? Like, do you feel that pharmacists are trustworthy? Because statistically, They are. They're amongst the most top trusted professionals in this particular Gallup poll. But when I was in pharmacy school, that was the thing that our professors were just like, hey, we're trusted, so make sure you are worthy of that trust. It's like, I get it, like we're really high up there. And so people trust us with their health, they trust us with their Dr. Crutchfield feels that pharmacists are trustworthy. I appreciate that coming from a physician. That's not the vibe I get from every physician. Mostly they're like, pharmacists are naggy. They nag me about how I prescribe things, but we're trusted. And I also often wonder if we deserve this much trust. I think a lot of the medication prescribing is well-intentioned, but it also is very, I think, overdone. And so you have a conflict of interest if you work for a store and your revenue is dispensing pills, and we try to get people off pills, but that revenue's got to go away. So what happens? And so we're trusted. We go through a lot of school. As I mentioned, I did a residency. Every pharmacist now graduates with a doctorate. So technically, I'm Dr. Jenks, but Dr. Crutchfield is a doctor. He's a doctor. If you're on a plane and you have an emergency, you want that doctor. You do not want this doctor unless it's a medication-related issue. So in which case I could help you, but then if it's, I went into pharmacy because I don't want to touch fluids and holes. So here I am doing a nice presentation about medicine. So I think we've talked enough about pharmacists, but let's get into the thing that we care about. And I'm going to focus specifically here on diabetes, but it's all encompassed in this metabolic syndrome issue that we face. And so I want to go back in time because right now seems pretty crazy. The last couple of years, it's only getting nuttier. So we're going to go back to my childhood because everything's better in your childhood because the 90s were the best. So back to 1994, my little kid just started T-ball last week. This is me, my first year of T-ball. So 1994, top grossing movie was The Lion King. If we all love that song, The Sign by Ace of Base. Top stories in the news, baseball strike, baseball work stoppage. History doesn't repeat, but it does rhyme. We're dealing with that right now. Healthcare reform fails. Whoa, it's like the news never changes, but they keep us afraid of everything. Sorry. And then Nancy Kerrigan attack. That has not happened again. So that is not something that has repeated itself. But here I am, pretty happy as a 7-ish year old. Ready to get started on my wayward baseball career. And as a country, our obesity and diabetes was not great, but not terrible. I was actually one of the heftier kids in my class. And I don't want this to sound insensitive, but I really missed the era to be a chunky kid if I was that size. Like it's really more sad. And we'll get to our obesity. This is adults, but we're an obese country. So you can see here, starting off in 1994, year 2000 hits, I hit puberty, so all that baby fat goes away, but I get braces, so girls still don't like me. We're talking about The Grinch Stole Christmas, Breathe by Faith Hill, Hanging Chads, remember those in Florida? Holy cow, simpler times. The USS Cole was attacked. The Yankees and Mets played in the World Series. And the Y2K, I remember Y2K, I had a friend that was building a Y2K bunker. His family built a Y2K bunker. Didn't ruin society, but social media did the trick a few years later. So Y2K didn't mess up, social media has. But something was happening and it was not good for our health. You can see here the shades of obesity and diabetes getting worse. And I just like to include this for completeness sake. And then 2005, I'm in college. We're in these same garnet colors as the University of South Carolina. So another Star Wars movie came out. I'm tired of those. We Belong Together by Mariah Carey was the #1 song. And we literally would track it at the restaurant I worked at that summer between high school and college. And there was a day where it was over a dozen times this song was played. But I was a fan of Holla Back Girl by Gwen Stefani. That was my unofficial high school graduation anthem. Hurricane Katrina hit, gas prices rise, history rhyming and repeating there. And I actually set an SEC record, according to me, of the most point after touchdowns and field goals caught in a season with 4. I caught 3 in one game, and you can see number 4 here that I caught against the University of Florida. So obviously my greatest athletic achievement. But things are not looking good. We're getting more obese, that leading indicator for diabetes trails. And I was in the thick of it in South Carolina. We were in the obese belt. 2010, spring picnic, getting ready to close to graduating pharmacy school. We're talking Avatar is the top movie. Kesha's TikTok was the top single, which is making me feel super old right now. We had the Chilean miners rescued with the BP oil spill, and the Saints won their first Super Bowl. And it's not getting better. So I graduate the next year. It's like, what's next, right? I'm ready to take on the world. I wanted to be a healthcare hero, take care of people with my medicines, right? Well, with all these medicines, clearly we're going to be fixing the problem. We have to be. Well, a few years into my practice, it felt like this old parable Sisyphus. This was the parable of a guy that was condemned to ceaselessly roll a rock to the top of a mountain, and the stone would just fall back under its own weight. And they thought that there's no more dreadful punishment than futile and hopeless labor. Futile and hopeless labor. And that's what it feels like practicing medicine or practicing pharmacy. Because 2015, we've never had more medicines available to treat diabetes. We've never had more pharmacists. Like there's this boom of pharmacy schools that it's just kind of a crazy side story that the number of pharmacy graduates like doubled in 15 years because we need these medicines. And I don't think that's a great sign for society, but that's besides the point. So here we are in 2015. This is the point in my career where I felt like pushing that rock up the hill over and over again because my patients don't get better. I put them on the right medicines and maybe their blood sugars get better, but they're still obese or they're not living a really healthy life. And it was around 2015, 2016 that I took the low carb red pill and haven't looked back. My wife and I both were always pretty physically fit and active. You saw all those pictures of me playing baseball, which I guess if you've ever seen baseball players, that doesn't mean much. We're not the healthiest group of, and I use this loosely, athletes. But we would stay active and follow the normal advice. And we heard about this low carb thing and we just were curious and we learned and read and podcasted and there was no looking back. And now my wife works for one of the innovators in the world of low carb. I do my best to work with my patients on this. But as I said, my job is chronic disease management. And this is something that pharmacists are really bad about advertising for our services. We're known for dispensers. Some people know that there's pharmacists in hospitals. One of the reasons I became a pharmacist was because my mother had back surgery. The pharmacist was the one that helped to manage her pain kind of the most. And I thought, hey, I could get behind this. You're making a difference. But we're told that these chronic diseases are progressive and irreversible. And I'm going to get to some more slides here in a bit that show that that is not the case. There's evidence-based treatments to reverse these chronic diseases. But on the one hand, as a pharmacist, this job is like, not to disparage my retail friends because it's a very necessary job, but this job is much more mentally fulfilling than just they don't just put pills in the bottle, but the dispensing role of a pharmacist. So that's good for pharmacy. What's bad for pharmacy and bad for society is that we need this much management. I work in a healthcare system, and anyone who works in the healthcare system, you saw the rates of obesity and diabetes, that the fact that there's this much demand for managing this. And when we say management, it's get your blood sugars under a certain number, get your hemoglobin A1C under a certain number, get your blood pressure under a certain number. How do we do it? Well, I talk lifestyle. There's a reason I'm in the AZ low carb group and not the AZ polypharmacy group, right? We want you on the fewest pills as possible. Polypharmacy means lots of medicines, by the way. So there's a reason that I've learned enough that like the idea of management, patients I'll tell that we could reverse it, and they've never been told that they can reverse it before. So one of those big measures that we talk about is the hemoglobin A1C. And so for those who are not familiar, the hemoglobin A1C is a 3-month blood sugar average. And it's a numeric assessment here to assess for glycemic control. So how's your blood sugar doing over 3 months? Because where I work, if you don't have insulin injection shots, we're not supposed to give you a glucometer to check your fingers. And forget about getting a CGM. That's like literally an act of Congress. I work in the government. So we check every 3 months to trend how you're doing, which I think is ridiculous because if you've been eating or doing something over the course of 3 months, tell me what you've been eating the last 3 months. Are you kidding me? But it's the thing that we have focused on. When I was in pharmacy school, it's A1C. We got to get that A1C down. And as you see here, it's used to optimize medications and draw conclusions about how well we're managing diabetes. And so I have patients that are just obsessed with my A1C this, my A1C that, and I don't disagree. I think it's a useful tool for trending. But you can see here that like the goal for oftentimes is getting it under 7% as a measure, and there's a little range of error. So we care about this A1C, don't we? Because if we have a controlled A1C, the numbers look good, and I'm a huge skeptic of the So recently I wrote a book about the administration issues that we face in medicine, but we see the A1C, it's a quality measure. Oh, we check that box, right? But what cost does this controlled A1C come at? Dozens of medications, literally dozens. I have patients that are on 50 medicines. It breaks my heart. Blood sugar checks. So if you're on medicine, especially if you're injecting insulin before every meal, if you're going to do it, you better be safe about it. You got to be checking that finger. And I have patients that just say, like, my fingers are raw and they hurt, and I don't want to check my sugar anymore. I don't blame them. Hypoglycemia or low blood sugar. If we're giving you extra medicines to lower your blood sugar, sometimes we can mess up those doses and cause a dangerous low blood sugar episode. I have a family member that was on a specific class of medicines called the sulfonylurea. And I'm down in Tucson, so I won't use the geography, but essentially they got in their car in the morning after taking their medicine, and they ended up on the other side of town in the median and don't know how they got there because they got so hypoglycemic. Their blood sugar got so low, they didn't know what was going on. So this can be very dangerous. Obviously, money, the talk of insulin prices is never ending. I would argue that if we could fix people's health, we don't need the insulin. I would also say that there's some insidious things coming from the pharmaceutical companies that make this cost so much, but it costs a lot of money to maintain blood sugar on medicines. And then time, think of the time and the mental energy of, I got to get my medicines out. I got to take a pill. I got to do a shot. I got to check my finger. I got to dispose of my syringe. I got to go to the pharmacy. I have to pick it up. So if the number looks good, but what quality of life? Like, that's really what I care about, is giving people their life back. And what else? Like, what else are we missing at the cost of medicating this thing that can be reversed with diet and lifestyle? And this talk is not as in-depth on the specific lifestyle changes like low carb, lowish carb, keto, all approaches that the practitioners here use that I think we're proponents of. Again, our name is AZ Low Carb for a reason, but it's not talked about enough. And I'll be quite honest, at my facility, I get a lot of pushback from others and other disciplines that say low carb is not sustainable, it's too hard. And then I just say, like, how sustainable is 50 medicines a day? Like, is that a life you want? And that's what gets me so angry. Sorry, I raised my voice slightly. I try to keep it mild-mannered. I won't yell on this because it's being recorded. I don't want to hurt anyone's ears. So yeah, success is, I mean, this was something that made me think of like a patient the other day where it's like, they were excited. My A1C is 6.8%, and you're on 25 medicines. Like, this is not success. This is sad, and we need to fix it. And here's the thing, we can get this A1C down, but many medications don't reduce the risk of cardiovascular disease. So with high blood sugars, with diabetes, one thing that we really are concerned about is the complications of them. What can kill you? And heart disease is one of the biggest ones. And so these are just some we use acronyms when we do medical trials because they think it's clever. I don't know. I'm kind of over these acronyms, but 7 randomized controlled trials looking at patients who got their A1Cs really low using medicine, so not using lifestyle, failed to demonstrate a reduction in heart disease. So the good news is your A1C is really good. The bad news is you died of a heart attack. Like, that's, in so many words, what we're saying here is, like, I can get, like, if you get your A1C down to non-diabetic levels by not taking medicines, by eating appropriately, using the lifestyle that we talk about, we're not talking about that. We're talking of, we gave you these shots, these pills, we made your A1C good, but it doesn't improve the thing that we really care about, that root cause. And you can see here, here's a fancy list of diabetes medications. And so I'm not going to do a pharmacy lecture on this slide. What I do like to point out is green good, red bad. And look at all of these classes of medicine. So there's metformin, and then yellow is neutral. So it doesn't really cause high insulin, it doesn't cause a low blood sugar, it doesn't increase weight, and it doesn't really help with preventing heart disease. And look at how many classes of medicines we have and how little green there is in outcomes. Like, how few of our medicines actually save your life. Sulfonylureas, so medicines like glipizide, glimepiride, glyburide, insulin, anything that we're injecting into you, they will make your insulin resistance worse because we're giving you more insulin. They can cause low blood sugars. They'll make you gain weight. And there is actually an increased risk of cardiovascular problems in the literature. So all these medicines we're going to give you to make your number good, but it isn't going to save your life. Or at best, it won't make you at higher risk. So I'm happy that we can entertain questions on specific medicines. The two classes that have the most data on improving some of the problems and complications of diabetes, SGLT2s, you've probably seen these advertised on TV, Jardiance, and the GLP-1s, Ozempic, Trulicity, and Victoza are three that you'll probably see on TV, which is another issue, by the way, but I won't, this isn't a bash the direct to consumer advertising lecture, unless we want it to be in our Q&A, and then I will bash away. So the point here is that these medicines are there, but they're not, there's very few that are actually going to improve the things we care about, which is like not dying of problems. So how can we treat the root cause and reverse this chronic disease? Because again, I get patients who've been on medicines for 5, 10, 20 years, and no one has ever told them that they could reverse type 2 diabetes. But according to the VA and Department of Defense type 2 diabetes guidelines, and this is the organization under which I am, looking at reversal and improvement, they actually recommend a low carb diet. They were one of the first to recommend it. It's pretty awesome if the people there actually listen to it. It didn't fight me on it, but that's another story. So, and then the ADA, the American Diabetes Association, like the diabetes organization, reducing overall carb intake has demonstrated the most evidence for improving blood sugar. The most evidence. So again, let's focus on this, because when we talk to our doctors about going low carb, they say there's no evidence for it. Well, the ADA says that there's the most evidence for it. And I'm not here to be snarky, because evidence can change. There could be a study that comes out that says eating donuts provides the best evidence. Like it was probably sponsored by Krispy Kreme or Dunkin'. But the point is that when we're trying to make an argument for a medical intervention, we want the most evidence possible. And then low carb eating patterns have been shown to reduce the A1C and need for anti-hypoglycemic medication. So essentially, de-prescribing, it's easy to put medicines on a patient, but if we want to take them off, this has shown a lot of evidence to help reduce the need for those extra pills and shots. And again, among the most studied patterns for diabetes, for type 2 diabetes. So this is powerful information to take with you to your providers when you're embarking on this. And I've had patients that have been told to, like, excuse me, they'll be on medicines and they start eating low carb and they'll get a low blood sugar. And between my appointment and our next appointment, they'll meet with another member of the healthcare team, tell them they're having a low blood sugar, and the response isn't great. Tell Cory so we can give you less insulin. It's, well, you need to eat more carbs so you don't drop your sugars low. You need to eat your carbs to match your medicine. And my hair's falling out enough already. I don't need to be pulling any more of it out, but it just blows me away that there's not even a thought of, oh, we could just use less medicines. So remission of type 2 diabetes. So there's 3 clinically validated methods. And this is what I try to tell my patients is, so number 1, bariatric surgery. So if you'd like, we could cut your stomach out or part of your stomach out. Not appealing to me, but I'm squeamish. That's why I'm a pharmacist and not an awesome nurse practitioner like my wife. A very low calorie diet. This works. Like, I think a lot in the low carb world are like, calories don't matter. I'm like, the amount of energy you're taking in probably matters some. You just can't drink butter and cream all day and lose weight. But some people can. There's also like genetic freaks that are different than everybody else, but you can go on a very low calorie diet. Who here's done that before? I have. Like, not that I was obese or anything, but maybe prepping for a beach trip or something like that, going away to Europe, trying to impress in my younger days. I'm married now, so I don't care as much, but still got to stay in shape, chase my kids around. But is this sustainable? Is walking around hungry all the time? I would argue the people around me did not want me to continue to do it. If you're starving yourself, you're grumpy, you're not focused, things aren't as good. Or we could do a low carb diet. And so, yes, this involves, when I talk to my patients, like, I meet them halfway. I'm like, I get it. You like pizza, you like this, you like that. Which pain do we want? The pain of removing some certain foods, or the pain of taking more medicines? And some choose the medicines. And I want to give that shared decision making every time with my patients. And so the ADA consensus report just showed that adopting a low carb eating plan, so if we decide to do this and we're on medications for these conditions, can cause diuresis, which just means you're peeing, not fluid, and swiftly reduce blood sugars. And so consultation with a knowledgeable practitioner at the onset is really important to prevent getting dehydrated and to reduce the risk of low blood sugars, especially on certain diabetes medications. That's where the pharmacist can come in. So for me, it's all about leading on a team and safety. And so I think that pharmacists were experts in the drugs. Like, we went to school for 4 years. Some of us trained for 1 to 2 extra years just in pharmacy, plus our undergrad. Like, we'd like to fancy ourselves as the drug experts. But this is a team-based approach. I know we got a doctor on the call tonight. I think going rogue and just ignoring doctor's advice and not working together is silly. We want to have a team approach that we have the same outcome and goals in mind. We want to ideally work with a nutritionist or dietitian that can provide that information. The ADA recommends all members of the healthcare team should provide lifestyle education, and that's what I do within my scope and understanding. But we got to work as a team to do this safely and so that it's sustainable as well. Social workers as well also play a big role as far as the living situation, the food insecurities. But the big thing is safety. If we're going to do this, we want to not harm you. And fortunately for us, there's a great article on the adoption and adapting of medications for type 2 diabetes on a low carb diet. This is not we call a journal club in healthcare. We're not doing that, but just know that if you're going to a doctor and they're like, I don't know what to do if you're going to do this low carb thing, you're on all these meds, they lay out a very simplified evidence-based approach to safely de-prescribing medications. So if you're doing low carb, there's certain medicines we should just stop. So the big ones are sulfonylureas. They work by making your pancreas make more insulin to lower your sugar after you eat carbs. Well, if you're not eating carbs and your insulin goes up, your sugar is going to crash. We'll focus on mealtime insulins, so short-acting insulins. If you're on there's some insulins that are short and long-acting, you just want to go to long-acting. There's a medicine called alpha-glucosidase inhibitors. They work by just basically preventing your carbs from breaking down in your gut so you don't absorb them. If you're not eating carbs, let's get rid of medicines. Patients love that. And then Jardiance, that class of medicine, SGLT2, it's either a stop or a caution, because this class of medicines can cause a mild ketosis. And I find hilarious that we can't prescribe these fast enough for people who have heart disease, heart failure, and kidney disease. But if we try to tell someone with heart disease or kidney disease to go on a ketogenic diet, we can't do it. So just to recap, if the drug company says it causes ketosis, it's okay because it's a drug. But if we try to do the diet, it's bad. I'm sorry, I'm just being a snarky jerk right now. But the point is, we want to be cautious with these because it can dehydrate you. It can put you into what's called ketoacidosis. So mild ketosis, good, often confused with ketoacidosis, which is bad. So this is like it's a toss-up depending on how much carbs you're eating. And I have patients that do like low-ish carb that stay on it, and some that I don't mess with. So, and then the long-acting insulins, we're going to be cutting them a lot. And then there's a class of medicines called TZDs. They call us weight gain. We're trying to lose weight with this thing. I just take them off. They're one of my least favorite drug classes. So, okay, okie dokie, metformin, it's as old as dirt. Keep using it. Very neutral, very staple medicine. And then these two classes of medicines here. So GLP-1 agonists are medicines like Trulicity, Ozempic, Victoza, and then DPP-4 inhibitors, medicines like Januvia. They're fine. They're not going to cause the dangerous side effects that we worry about. And so the other thing we got to worry about too is blood pressure, because you're going to be, when you lower insulin, insulin causes your body to hold on to fluids. So less carbs equals less insulin equals less fluid in the body equals you're going to be peeing out more fluid, which means, I mean, we put people on diuretics to help them with their blood pressure. So you're having a blood pressure lowering effect. So be very cautious about getting dizzy. So again, blood pressure medicines can start coming off. Hyponatremia just means low sodium. So we tell people not to eat salt to help lower blood pressure, but really the bigger effector of the blood pressure and salt retention is high insulin. So if you're not eating carbs and having high insulin, telling your body to hold on to salt, then if you eat salt, it will not cause some of the issues. And some patients are salt sensitive. So just being cautious and maybe reducing or stopping diuretics, and then closely monitoring blood pressure. And then anything that can cause a low sodium, we want to keep an eye on too, and checking kidney function. And then warfarin or Coumadin, it's a blood thinner. People do low carb, they change their diet up. They might actually be eating more leafy greens, or vitamin K can affect this one. And then any medicines that, if your doctor is monitoring levels, keep a closer watch on. Safety, safety, safety. So, but can this be effective? Can we really de-prescribe and reverse chronic disease? And so this is a really cool study out of Canada. we're America, right? But we got to give Canada some due here because they have some pretty progressive pharmacy practices. And here was a trial of pharmacist-led therapeutic carb and energy restriction for type 2 diabetes. And I apologize, I did not get the little box to show you the big important things. But essentially, there was a group that got pharmacist-led therapeutic carb restriction and a group that got normal care. And the therapeutic carb restriction group was effective in reducing the need for blood sugar medicines. And 35% of patients totally stopped their diabetes medicines. 0% in the normal group did. We also saw improvements of A1C, blood pressure, weight, so triglycerides. So all the things that we're treating with medicines, we're getting better because we're lowering our carb intake, and the pharmacists were well positioned to help safely manage these medicine reductions. So big up for pharmacy, big down for the USA, because we don't let pharmacists do cool stuff like this as much. But hopefully we shall change that tide, I guess. So real life. Okay, so I've gone through the history. I've gone through what I do. I've gone through some of the medicines. I've gone through another trial that showed it. But I have a couple of cases from real life that I want to share with you about the power of not even perfect low carb diets. The ones I give you I guarantee they were not measuring ketones and counting calories. But I had Vince, name's been changed, had an hemoglobin A1C of 15%. So that's really high. If you're unclear, like not like diabetic is like a little like 6.5% and higher. If you're diabetic, we want to manage your medicines under 7%. 15%, that blood sugar is super high all the time. And so when he came into my clinic, he was referred to me. He was on metformin twice a day and 25 units of long-acting insulin. And his blood sugars were hanging about 150 fasting in the morning. So we call it reasonable control, especially compared to like a 15% A1C. Holy smokes. And he cut back on his carbs somewhat, but was stacking on popcorn and drinking milk. So I gave him some low carb education, gave him an officially sanctioned handout from my institution. So if anyone wanted to get me in trouble, I would point them back to the website where I got it from. And so with a blood sugar of 150, that's not normal, but I did something crazy. I said, you're going to start changing this diet and I don't want you to go too low. So I actually lowered his insulin by 5 units a day, which is a big reduction, but he was very motivated to get off insulin. And so type 2 diabetes is a disease of too much insulin. It causes the insulin resistance. So by lowering insulin, we're addressing the root cause and helping facilitate weight loss. So 3 weeks later, I followed up with him closely. He'd stopped popcorn, less milk, limiting his other carbs and sugar, his blood sugar. So remember, I cut his insulin by 20%, and his blood sugar dropped 15 points. So I said, let's cut that insulin down a little bit more. Well, 3 weeks later, he's still low carbon. Blood sugar, it's even lower, but he's on less insulin. So I said, let's cut that insulin some more. And he was feeling this. He was like, this is great. I don't want to be on shots. And so a couple months later, his A1C was cut more than in half, and he's totally off insulin. And I still follow up with this guy 3 years later, only on metformin, and A1C hovers around 7%. The perfect success story would be like his A1C is 5 and he's off metformin. But we live in the real world, and this patient has certain challenges that this is as good as he's been for a while. So, but I think when we think of like big risks, all the damage that your blood sugar is doing at 15% plus all that extra insulin, you've cut that in half. And that to me is that real life example. It's not there's no keto, well, there's like keto text-ish books, but if we had a textbook case, this wouldn't be it because he's not like full blown low carb keto, but he's doing pretty good, all things considered. And so then I have David, he's a 76-year-old person. So can we teach an old dog new tricks? He came to me, his only medicine was 60 units of long-acting glargine insulin a day. And his A1C was 9.3%, and the doctor, he needed a new hip, and he needed to be under 8% for them to do the surgery. Because if your blood sugar is high, that puts you at high risks of infections and other issues if you're going to be cut into for surgery. So surgeons, they don't like liability. So they say, you got to get that blood sugar down. So he came to me, and he was drinking 3 to 4 Arnold Palmers a day. So lemonade and iced tea. So lemonade, and they were like the Arizona brand, like 32 ounce, it's iced tea. It's good for me. And I looked it up. I'm like, dude, you're probably drinking like 120 grams of sugar a day. And so I told him, stop drinking sugar. That's all I did. I didn't talk about food at all. I just said, stop drinking your sugar. And again, I lowered his insulin to 55 units a day because safety. I would rather him be a little high than get dangerously low. So what happened? 3 weeks later, on his own, he cut it all the way to 40 units, and he cut out all his sugary beverages and was also being more physically active. But one thing I also did is, like, we talk about de-prescribing. Cory, why are you prescribing? I started him on metformin. But what I find is when people start making these changes, the goal to me is to get off insulin. That's like the worst drug for type 2 diabetes. If I can put you on metformin, a long study, relatively safe, all medicines have side effects. Don't come at me, I know. But if I can use that as like an insulin sparing medicine, then I was able to get him, I cut his dose by 25% of insulin. And then fast forward 2.5 months later, since the initial appointment, this guy went rogue and just stopped his insulin on his own because his sugars have been doing so good. He was on 1,000 milligrams twice a day of metformin. His fasting blood sugar was doing relatively good. I know we're in the low carb world. We're like, it's over 100. This is terrible. You got to remember, it's all relative. So he was on 60 units of insulin a day, 60. And in 3 months-ish, he's on 0 units of insulin. His A1C went from 9.3 to 7, and he got his new hip. And he was very happy about that. So these aren't like perfect low carb success stories in that they did low carb perfectly. But I think looking at that awful amount, that sea of red that we see in our statistical obesity and diabetes is, I don't let perfect be the enemy of good. We just got to stop the bleeding. That's what I tell patients. I know we're recording this, so I won't say the swear word I actually say, but I tell them, I don't need you to be a perfect eater. I just need you to stop being such a crappy eater. And they're like, yeah, I know, I've been pretty bad. I'm like, yeah. So like, I start very simple, like one meal a day, let's do better. Or if you're drinking soda or juice, let's stop that. And I can't tell you the number of people that are drinking like the iced teas that have sugar in them, or like energy drinks, or there's even I'm like that. This is clearly not sponsored by Arizona brand beverages, but there's an Arizona green tea with honey, and they're like, oh, it's got honey and it's green tea. It's got like it's like got more sugar than a soda. And I'll just, because I do a lot of phone calls, I'll literally look up on the internet, like, oh, you're drinking that. Okay, how many a day? 2. Okay, you're drinking 100 grams of sugar a day, and they're like, I had no idea. So it's baby steps, but then you get people that get their life back. Like, this is what de-prescription is about. Is this guy can now be active and swim and do things. The other guy now doesn't have to inject himself. So the discussion. So when you go to your doctor, this is what my book's about, is the human interaction. So the barriers is that the ways of eating are ingrained. Hey-oh, get it? Because we all say, okay, we need to eat grains. So this is where I want us to have some empathy for the doctors that are seeing us, and the pharmacists, if you're seeing a pharmacist, good on your clinic. So it's hard to give up what you've been taught and what is the bedrock and foundation of your education. I've always assumed that I don't know that much. So when I came across low carb and it was different than what I would have expected, and I found out that medicines aren't as great as I thought, I was like, yeah, you're probably right. So let me learn more. But a lot of people aren't as easy to give up what they care about. Lack of time. We've talked now for almost 50 minutes. There's nuance, there's issues. And I get why we just add medicines, because it's quicker and easier, and our medical system and the way we're supposed to see patients really stinks. So it's easy to bash doctors. Dr. Crutchfield, I'm not bashing at all. I'm coming to bat for you because they're under different pressures too. We want to understand that. The doctors didn't go to work, and I don't go to work to ruin patients' lives. Our lives are ruined by our administration, and they need to read my book. Anyways, lack of interest. Also, keto and low carb has this like label of like this diet thing. So if you could just bring in like an ADA statement that's printed, that's like, this is from the ADA. Can you be interested in that, please? And then, of course, like other patients are like, I've had dozens of patients that see Dr. Oz, or they heard it's on the podcast. Like, I had a patient the other day who said metformin was like the top 10 worst drug of all time. I'm like, thalidomide gave babies flippers. This is not a top 10 worst drug. Oh my goodness. But I was like, but this is what their previous doctor told them. So it's hard when healthcare providers get new info. Again, like, this isn't a book advertisement, but it's to be open to the idea of like investigating that. So the evidence, we have our 3 proven reversal strategies you could bring up. The ADA is actually on your side, kind of, sometimes. In this little particular sense, they are on your side. Show them that you want to do this safely too, because I think a big fear from providers is, what if they do this and they have a heart attack? Or what if they do this and they have a low blood sugar problem? So tell them that you want to do it safely and come up with a plan. Tell them, give me a month, give me 2 weeks, give me 1 week of, if you want to, like the carnivore challenge of like 1 week, like eating meat for 1 week is never like, that's not going to cause a problem. Give me 1 week, 2 weeks. And this is what I actually just plead to my family members that need to change their eating ways. I'm like, give it 2 weeks of doing this to see how you feel, to see what happens with your markers. And honestly, a lot of times the patients that come to me, they have nothing left to lose. Like, I've tried everything. I've tried dieting, low fat, low calorie. I go run all day long. It doesn't work. Nothing works. And then you lose. It's a term called learned helplessness. And so literally just tell them, like, I've tried everything else. What's there left to lose? And I can't fix the conversation you'll have with your provider, but this is trying to come at it from both sides, finding a common middle ground where you can be happy. And so remember that most healthcare professionals got into this thing to help people. We didn't get it to be burnt out and bitter. It just sort of happens over the course of our career. A lot of them are super stressed between the demands of their patients, their bosses. COVID has not helped things. Student loans, pharmacists, doctors come out with a crazy amount of student loans. Like, financial stress can be, even high earners can have that stress. Try to be patient and empathetic. It's hard when a lot of patients I talk to will say, you're the first person that's listened to me. Yeah, it's hard being ignored. It really sucks. So maybe it is, if they don't listen to you, maybe it's time to find a new doctor. But ask if they're listening and make sure that you listen to them too. Ask them why they're afraid of doing this thing. Hear their arguments, because they could have very valid arguments. Know that there is evidence, and ultimately it is your health that we're talking about here. So I say, instead of managing chronic diseases, why not reverse them? And then you could fire your pharmacist. So put me out of a job. All right. I joke about this, but I'm like, I'm too young to be like, I'm too old for this stuff. But nothing would make me happier to have my boss say, well, Cory, there's no more diabetes. So you're fired because there's nothing for you to do. I'd be like, great. Imagine all the lives and happiness, joy people will have back. Medications are a Band-Aid. Many are worse. And I'll say this, pharmacy boy, some have a place. If your blood sugar is 400, we got to get it down. Like, there's dangerously high blood sugars. There's a time and a place for medicines. My goal is to minimize them. And it's a two-way street of working together. And I want to give patients their lives back. I'm tired of, like, no one's life should revolve around their pill box. So if you need some help, Metabolic Multiplier has some awesome resources. So this is, I think Cecile maybe will share that in the chat. And this is the time for open questions and discussion.